So then let's talk about neurological causes of coma and what are the risk factors and what causes it, and what are some of the symptoms and signs. So basically it can be a cerebrovascular accident or stroke, which is the layman term. And in cerebrovascular accident, people can have an embolism or hemorrhage, and then people can also have an intracranial mass or tumor or cancer, which can cause transtentorial herniation, which can cause loss of consciousness. And then in any case, whenever the cerebrovascular accident is huge and is causing disruption in the ascending reticular activating system, then people will go into coma. So basically that's the mechanism. So this really doesn't have to be, not every CVA and every intracranial mass will cause loss of consciousness, but whenever it's widespread and whenever there is herniation, it will people will lose consciousness. And in hemorrhage, you have subarachnoid, intracerebral, and subdural hemorrhages. And then just the most common site that can cause coma, because it's the vertebral basilar system, and that is something to remember, because that's where that's where the circulation causes too much damage. And then with any of the embolism or hemorrhage or mass, people can have focal neurological deficits. So there are lots of different neurological deficits that can occur. They range from one variety to any variety. So there are lots of them, but we'll just talk about real most common ones here. So the most common presentations will be people can have facial asymmetry, aphasia, slurred speech, diplopia, dysphagia, upper and lower extremity weakness or numbness or things like that. So anything that makes you think that there is a deficit, you will think, okay, maybe one of the three things have happened. And then in case of hemorrhage, people have are much more likely to get a headache because they have hemorrhage, so there is a lot of raised intracranial pressure, so they will get a headache. So very important to keep that in mind. Headache is going to be much more common in the case of hemorrhage and not as common in embolism. So this is going to be a very special kind of headache. It's not going to be your regular headache. The features will be, this is going to be more severe early in the morning or after they get up from a supine position because the pressure is so high. And then also when they bend over or they do anything that raises the pressure even further, for example straining, they will get a headache, and a lot of the times they say it's the worst headache of their life. In addition, they have nausea and vomiting. They can have neck stiffness, so you can see that they have some symptoms of that are similar to meningitis, but there are some differences too, so they don't necessarily have a high-grade fever. They may have papilledema too. And then also this patient is not going to just get a hemorrhage out of nowhere. They may have some risk factors that will give you further indication that maybe it is subarachnoid hemorrhage. In case of mass or embolism, also they may have risk factors. And then there is something really quick about Cushing triad. So that is a phenomena used to describe extremely elevated intracranial pressure that causes bradycardia, hypertension, and hypopnea. So when they have these three features present, and you can see all these three are vital sign features, then we say that okay, the patient maybe has Cushing triad because of extremely high pressure. And whenever you're suspecting subarachnoid hemorrhage, particularly in this case, then you will of course do a lumbar puncture. First we'll do the CT scan to make sure that there's no chance for herniation, but then if that is clear, you can do lumbar puncture, and then there will be three possible scenarios. It can be totally clear, or it can have a blood spot which will indicate maybe it is a traumatic tap. But if the red color starts to disappear soon and changes to yellowish, then that is called xanthochromia. So in that case, this is subarachnoid hemorrhage. So it's not a traumatic tap anymore. So that's how you differentiate. So remember xanthochromia here. All right, so when people have infarction or cerebrovascular infarction, that is basically opposite of hemorrhage. There is less blood supply as opposed to too much blood. So it is hypoperfusion. It's similar to myocardial infarction, except that it's happening in the brain. And these people usually have risk factors. So again, these are the risk factors. So atrial fibrillation, hyperlipidemia, diabetes, smoking, and clotting disorders. And then when you're suspecting it, because there was some neurological dysfunction and the headache was not really that severe and people had any of these risk factors, you'll do the diagnostic test. CT scan would be the first one because it's the quickest one, but sometimes it can miss an infarction in the early stages. So then the MRI will definitely give us the answer. And then EKG will be needed for AFib, and then of course you will have to do transesophageal echo to make sure there is no clot in the heart, and then clotting studies need to be done. And the treatment, of course, if the patient arrives within a reasonable time, between 3 to 4.5 hours, you can do thrombolytic therapy. Otherwise, heparin, aspirin, Agrinox, and the anticoagulation on the long-term basis can be done. And if a patient has any risk factor for intracranial hemorrhage, it can be one of the 3 forms. Again, like I said, so subarachnoid is the most important one because this happens most commonly in the face of hypertension and smoking and diabetes. So of these 3, hypertension and smoking are the biggest risk factors for subarachnoid hemorrhage. And then there are some other causes of intracranial hemorrhage, especially subdural hemorrhage can happen because of trauma. So trauma is the big factor that can cause it. And then of course there can be bleeding disorder, cocaine and amphetamine can cause it, some prescription medicine, for example warfarin can do it, some blood thinners can do it, and then of course anything that can cause generalized bleeding in the body can cause hemorrhage. Another thing to keep in mind is very extremely low platelet count, like when the platelets drop below 25, thrombocytopenia, that can also cause spontaneous bleeding. So those are the things to keep in mind. And the diagnostic test, of course, will be the CT scan will be more sensitive, so it will pick up the hemorrhage much more easily, and then MRI can also be done. And of course you will treat the hypertension, you'll treat all the risk factors and rehabilitate the patient. Here is a subarachnoid hemorrhage right here, very subtle. Here's a big one right here. And then this is just the blood supply of different parts of the brain, and we'll talk about different syndromes and lesions here in a second. And this is just a slide from up to date, so don't worry about it too much, but let's look. Okay, so I made a couple of videos a couple of years ago about where is the lesion in the brain. So whenever there is a neurological deficit, feel free to watch these. There are 3 of them. Where is the lesion, part 1, part 2 and part 3. So you can watch them if you want. It's not a part of the course, it's just totally up to you, but they're about 15 minutes long each. So the most important thing to remember is basically when it comes to exams and boards. So this is a very favorite board question about facial paralysis, or so remember to distinguish between Bell's paralysis and the upper motor neuron lesion of the facial nerve. So whenever there is a complete paralysis of one side of the face, the entire face is paralyzed, then it's a lower motor nuclear lesion of the 7th nerve. Whenever there is only the lower part of the face is involved, then it's the upper motor nuclear lesion. So remember, the upper motor neuron lesion will spare the upper part of the face. So that's how you distinguish. So it's very important to keep it in mind, because you don't want to just tell the patient you had a stroke. This happens a lot. People have a facial nerve paralysis and you know clearly it's Bell's paralysis, but they think they had a stroke because somebody told them that. So that's why you need to distinguish. It's a very commonly asked question. And then there is rules of 4. So rules of 4, I'm sure you're familiar with rules of 4 already. This is a genius, I think somebody invented rules of 4 and they published it. So I stole this slide from somewhere, so it's not my own slide, but anyway, they are very important rules to remember. They are basically anatomical rules. So if you remember the rules, then you will be able to figure out where is the lesion. So just quickly, you already know about it, I think. So the first set of 4 rules is that there are 4 structures in the midline in the brain that begin with the M, and they are motor pathway, medial meniscus, medial longitudinal fasciculus, and motor nuclei. And then the 4 cranial nerves that are integers of 12, or they go into 12, are the medial, and then the others are lateral, and the cranial nerve 1 and 2 don't follow this rule because they have their own brain. So 3, 4, 6 and 12 that all go into 12 are going to be medial, the others are going to be lateral. And then there are 4 lateral structures or on the side, which are, you already know, spinocerebellar, thalamic, and sensory nucleus, and the sympathetic pathway. So these 4 S's are on the side or lateral. And then there are 4 cranial nerves in the medulla, and that are the lowest 4, then the 4 in the pons, and 4 above the pons. So we'll talk about that here in a second real quick. So basically this is your cranial nerve 1 through 4 in the midbrain and above the midbrain. So basically 1 and 2 is above the midbrain, 3 and 4 are in the midbrain, 5, 6, 7, 8 are in the pons, and then 9, 10, 11, 12 are in the medulla. So just a couple of real big points. Whenever there is a lesion in the frontal lobe, people usually have personality change, so that is how they present. So usually it's a mass, usually it can be a cancer, so that is just something like a high yield point to remember. Then people have if they have an upper motor neuron lesion, it's a spastic lesion. So we're talking about motor paralysis, so it's a spastic lesion. If it's a lower motor neuron lesion, it's a flaccid paralysis. So keep that in mind. In order to localize the lesion, anchor at the cranial nerve. So this is just my little tip here. This is kind of how I can figure out where is the lesion, because I anchor at the cranial nerve. So just first figure out if whatever the motor deficit or the sensory deficit or the neurological deficit is the motor nerve, is a cranial nerve involved in that or not. And if it is, I will anchor my lesion there. I will say, okay, because I know it's a fifth nerve problem, the lesion is in the pons, and so wherever. So you anchor at the cranial nerve, and then you figure out the rest. So if it's an infratentorial lesion, then of course it's a lower motor nuclear lesion of the cranial nerve. So that will be on the side, the problem will be on the side of the nerve, and then the weakness, the motor or the sensory weakness will be contralateral to the nerve. So this lesion will cross. So that's how you say that the two abnormalities or deficits will cross each other. So this is going to be your infratentorial lesion. If it is supratentorial, however, let's say it was in the forebrain or cortex or somewhere, then the cranial nerve deficit will be on the same side as the weakness or the motor problem. So these two will be ipsilateral. So, and the cranial nerve lesion will be upper motor neuron lesion of the cranial nerve. So that's how you can, that's one way to just kind of roughly figure out real quick, but then there are of course more things. So these are the slides that I made myself, so you can look at them. So basically again it's reiterating the rules of 4. So you can see there are 4 things that start with an M that are medial. So they are motor pathway, which is corticospinal tract, your medial column, which is basically, or medial meniscus, which is basically your dorsal column, position and vibration sense, and medial longitudinal fasciculus, and the motor nuclei. So basically they are all going to be on the medial. Then 3 and 4 are going to be in the midbrain, and they are going to be in the medial also, because they're going to 12. 6 is going to be in the pons, and 5, 7, and 8 are also in the pons, but they are lateral because they don't go into 12. And then you have 9, 10, and 11. That 10 and 11, they are lateral in the medulla, and then 12 are medial in the medulla. So this is how you kind of dissect, or you, so just imagine this is brain. This square is a brain. No, actually the brain starts from here. So this is all brain. It's a very flat brain, but anyway, this is the medial. All of the square is the medial, and then this is the lateral outside. So you have your 4 M's here, and you have your cranial nerves here, and then your 4 S's are these tracts, and you already know about these. So anyhow, if you have let's say you have a cranial nerve deficit, let's say there is a lesion in the medulla, and there is a paralysis of the tongue, so there's a hypoglossal nerve. So you know that the lesion is in the medial medulla, because and how do you know that it's in the medulla? Because the cranial nerve deficit will be on the same side of the lesion, and the motor deficit will be contralateral. So that's how you know, because they are crossing each other. That's how you know it is a medullary lesion. However, if it was supratentorial, if it was in the cortex, then you might have seen the tongue problem or the tongue lesion on the same side as the motor deficit. So that's how you know it is infratentorial lesion. Here is the blood supply. So you can see the posterior cerebral artery is going to supply the entire midbrain. The AICA, or anterior inferior cerebellar artery, will supply the lateral part of the pons. Basilar will supply the medial part of the pons. PICA, or posterior inferior cerebellar artery, will supply the lateral of the medulla, and anterior spinal will supply the medial of the medulla. So if you know where this is the lesion, you know what artery is involved. And there are interesting syndromes that get asked a lot, so like PICA syndrome and all the others. So that's why it's important to know the arterial supply. So let's talk about the syndromes real quick. So if there is a lesion in the medial part of the midbrain, then you know that it's your cranial nerve 3 basically, and your eye is going to be down and out to the same side. So that's the ipsilateral lesion. But there is contralateral motor weakness, so you know your motor pathway is involved, and contralateral dorsal column or medial meniscus is involved because your position and vibration senses are low. So this syndrome is called Weber syndrome. So if you have a combination of these findings, then it is Weber syndrome. And how do you know that this is in midbrain? Again, because there's cranial nerve 3, and then there is opposite direction weakness and position and vibration sense loss. If there is a medial Tyne syndrome, so this is another syndrome where you have number 6, cranial nerve 6 is involved. So it is in the pons, you know, and it's the medial side of the pons because that's the only one that's living there. So the patient can't look to the side of the lesion, so there is ipsilateral paralysis, and then also there is contralateral weakness of the motor pathway. So that's how you know it is medial Tyne syndrome. And then on the lateral side, things are more complicated because this is 5, 7, and 8, and then also you know there is spinothalamic tract, and you also know that there is what do you call the sympathetic pathway. So there are more things involved here. So you end up getting Horner syndrome here, which you know that it is ptosis, meiosis, and anhydrosis. And because of the 7th nerve, you have ipsilateral facial droop. So you will see that there is the only the lower half of the face will be involved because the upper part will be spared here. And then you have loss of corneal reflex, nystagmus, and vertigo because of the 8th nerve, and you have contralateral weakness. And then you have medial medullary syndrome, where your tongue is deviated to the same side. So again, this is the same side because so you know that this is a problem is in the medulla, and then on the opposite side of the tongue is going to be weakness in the motor areas, and then position and vibration problem. So that's when you say it is medial medullary syndrome. And finally, you have pica or lateral medullary syndrome. So pica syndrome is very commonly asked. So you have 9, 10, and 11 involved. So you have hoarseness and dysphagia and contralateral pain and temperature loss because you know there is a spinothalamic involved here. And then again, Horner syndrome can still happen because the sympathetic pathway is very long. It's very longitudinal, so it kind of goes from top to, it kind of traverses down. It's not restricted to one area. And Horner syndrome, again, ptosis, meiosis, and anhydrosis, whenever you see it, that is basically your Horner syndrome.